Okay, this is the last session. Rafaela, thanks for inviting me to give you some overview for what has been done primarily in India through our foundation. The Foundation for Primary Immunodeficiency Diseases is a charitable organization that we established about 9 years back in 2010. Let me see this. And with the aim of the mission of the foundation to increase awareness of PID, improve early diagnosis, support treatment, and when we have enough money to support the research. And this is both in India and US, but especially in India, and I won't discuss some of the projects that we are supporting in the US. This is our board of scientific advisor of the foundation. And the foundation is quite fortunate that we work very closely with the director of ICMR, which is an Indian NIH, as well as Secretary of Health Research, and also the Minister of Health. And therefore, you can imagine what we could do in the last 9 years. Perhaps would have taken otherwise 20 years with the bureaucracy of the system. So we are very fortunate. So we have 8 centers. And as you can see, it covers most of the country. We are still planning to do 3 or 4 more. The 2 which are in the red, and we have the representative from those 2 centers as well as from SGPGI Lucknow. And as you see, I've colored them a little differently. Those 2 in the red, we have been able to convince the ICMR to designate them as Center for Excellence in Primary Immunodeficiency Diseases, and therefore providing the support for the research in primary immunodeficiency diseases. And then with respect to this conference, as you can see, 3 of these centers, the head of those centers are adult rheumatologists. So we have that connection of the pediatric to adult rheumatology, which we need for this group of diseases. Now, to contribute to some of those missions, the lack of awareness, the foundation support their annual introductory course in primary immunodeficiency, and those are done in different parts of the country where we involve the faculty of the local medical school. Our FPID center, they organize number of CME, so that way you can see the awareness is disseminated all over the country, and both in primary immunodeficiency and autoinflammatory diseases. We, at the same time, about a few months later, that we also established Indian Society for Primary Immunodeficiency Diseases, and every other year a national conference is held, again, to educate and make more awareness about the primary immunodeficiency disease. There are rheumatology congress and meetings, and in these rheumatology meetings, there are sometimes the sessions primarily for autoinflammatory or primary immunodeficiency diseases. For the scientific development, we do an international primary immunodeficiency conference, and a number of us here participate in those. Also supports the training of scientists and clinicians who have spent time at NIH and other places, and also participation in international conference. The diagnosis in India in these centers is still a challenge from the point of view of the financial constraint. I hope by September we'll have a next-gen sequencing supported by ICMR. We do not have the whole exome sequencing, but there are now commercial laboratories who can do those sequencing. So there are at least 3 centers where molecular diagnoses are done. And as I said, those are the financial constraint there, and I personally working with the director of ICMR as well as the Ministry of Health and see where we take it. Definitely will need the help from Autoinflammatory Disease Network to help in our molecular diagnoses. For the early diagnosis, in India, we are also doing the prenatal diagnosis. As you know here, we do the newborn screening, but there we are doing the prenatal screening where there is a history of primary immunodeficiency in the family, and you have the next pregnancy. And to give you a flavor of these, there are two major centers which are done, which are the Center for Excellence. And you see here about 64 cases have been diagnosed with chordosynthesis. So these are prenatal diagnoses. Of course, they become a good source. Previously, we didn't have very much of the bone marrow transplant, so question was, even if we diagnose, what we do with that. So it gives you a flavor that we can diagnose them very early, and therefore the treatment part could be useful. The treatment, as you know, there are three major treatments for primary immunodeficiency: IVIG, biologics, and hematopoietic stem cell transplant. Biologics are expensive, and therefore is still a major roadblock with respect to the use of biologics. IVIG, here are about 10 states where the governor of the state have approved a free intravenous immunoglobulin for the children with primary immunodeficiency diseases, because we don't have the insurance system that we have in this country, and therefore it is very, very heartening to see at least so many governors have come along. And what I am working on it personally is to make and promote and try to convince the health minister that the primary immunodeficiency could be included in rare diseases in India, because once that is done, then the federal government is obligated to provide the treatment, whether that is intravenous immunoglobulin or the bone marrow transplant and so on. So I hope in next 2 years or so, I'm successful in convincing that. So here was when we started the foundation. There was one single really major transplant center which was doing the transplant for primary immunodeficiency disease, and now you see how many we have there. So we have really progressed in a very short time to provide the therapeutic modalities to children with primary immunodeficiency disease. And here to give you a flavor of just that one center and how many different type of primary immunodeficiency. Now in India, we are doing the hematopoietic stem cell transplant. And you see at the bottom, in March, there was a transplant. This was the first in Asia, and perhaps I think it's the sixth in the world, that C1q deficiency with SLE, and this was the patient who came from Mauritius. And the 10 out of 10 matched donor was her father. So it was a successful transplant. Again, we have constraint of these financial constraint for these transplants. So hopefully, if we can get the primary immunodeficiency diseases in the rare diseases, hopefully we should be able to provide the bone marrow transplant to most of our patients. Again, we'd like to have the participation of the autoinflammatory network. Perhaps one of the things which I was thinking personally was, if the biologics, if there are clinical trials, that other countries could be all in that, for the reason that those patients can get free at least the treatment during that clinical trial, as well as it gives another spectrum of the disease or clinical spectrum of the diseases to see the efficacy of those biologics. So we don't have a really a network in a way, in a real sense, the FP to have a registry for PID. So in lieu of that, the foundation itself have made a network in which beside our FPID network centers, there are a number of now institutions which have become the part of this network. And this will expand, and therefore we will be able to collect more data with respect to a variety of primary immunodeficiency diseases. And therefore we could link to other networks as well. And so, with the help of everyone, I think we can make the difference in the lives of the patient with primary immunodeficiency and autoinflammatory diseases. Thank you very much.
I would also like to thank Rafaela for organizing a wonderful meeting. For people like me who are interested in immunodeficiencies, in primary immunodeficiency, it's really amazing to see how much progress has been made in autoinflammatory diseases and immune dysregulation disorders. And I would also agree that we who are working on primary immunodeficiency are invading your territory, because if you look at the classification of primary immunodeficiency, in fact, all of the autoinflammatory diseases are now part of that classification. I think we're cousins, and rather than fighting, we should probably work together even more than we do. So what I'm going to do in these few minutes is to tell you about the Primary Immunodeficiency Treatment Consortium, which is the first network of centers in North America, not just the United States, but also Canada, dealing with observational studies and clinical trials for cellular and molecular therapy in a selected group of immunodeficiency diseases. So what is the PIDTC? It actually started 10 years ago. It is an NIH-funded initiative. It's a consortium of 45 centers in the United States and Canada. We specifically focused, because that was actually what was mandated by the RFA, on selective groups of immunodeficiency. We decided initially to focus on 3 disorders: severe combined immunodeficiency, chronic granulomatous disease, and Wiskott-Aldrich syndrome. The idea was to collect data in prospective and retrospective data, as well as cross-sectional studies, from cross-sectional studies in these diseases, taking into account the need that was obvious for collecting more detailed data than what the CIBMTR does. In the United States, we're mandated to report to the CIBMTR all transplants that are done, and these are obviously transplantable diseases, but the quality of the data, especially of the immunological data that are collected by CIBMTR, was suboptimal, and it was very difficult, in fact, to define what was the outcome in terms of immune reconstitution in these disorders. So that was one of the major goals of the PIDTC. We would not dictate any policy in terms of how these patients should be treated, so individual centers would continue to treat patients according to their own protocols. Differently from Europe, there was no consensus, in fact, on the type of protocols that had to be used for transplanting these patients in the United States. So different centers do different things, but we would collect the data and then analyze the data altogether and define, in fact, whether there would be differences between the protocols and what the outcome was. We have been working from the very beginning in very close collaboration with the patient advocacy groups, and there are many of them, with these specific diseases, or more general with primary immunodeficiency as a whole, like the Immune Deficiency Foundation and the Jeffrey Model Foundation. A major goal, which was also mandated by the RFA, was to promote research and education, and so the PIDTC supports research grants for fellows and junior faculty with an interest in primary immunodeficiency, and we do support pilot projects. We select a couple pilot projects per year. We also wanted eventually to implement prospective multi-center interventional studies, which have been lacking altogether worldwide in immunodeficiencies. And so the idea was to create a network and eventually create consensus towards development of therapeutical trials. So the PIDTC has been funded by the Office of Rare Diseases and the NIAID. has been co-founded. It was initially founded in 2009, has been renewed in 2014, and now again has been funded by NIAID, just by NIAID, and will start the new PIDTC cycle will start September 1st, 2019. You see here the steering committee, and we also have an external advisory committee and scientific planning committee, and here you have the list of the patient advocacy groups that are also involved in the PIDTC. I should make an important point that in the next cycle, we will have a special focus on immune dysregulation disorders. So Troy Torgerson from Seattle is actually the leader of the PIRD project. And for the first time, actually, this will include not just transplant, but also use of biologicals or any kind of treatment that is done in these patients. So we will have an opportunity to compare actually outcome of patients that go to transplant versus patients who receive other interventions. This is the distribution of the centers in the United States and Canada. There are 4 centers in Canada and 41 in the United States. You may see that there is a skewed distribution towards the East and the West Coast, and maybe some states in the center of the country, but very few centers in the northern part of the United States. And that actually is a problem because these patients often have to travel to other major centers to receive appropriate care. So we hope that actually in the future we will further increase the number of centers that participate to the PIDTC. So what have we done in these 10 years? And again, I mean, before the PIDTC started, there was really no registry dealing with patients receiving transplantation for immunodeficiencies in this country. There was and still there is a United States Immunodeficiency Network registry, but that collects in general information on all kinds of immunodeficiencies and does not have a focus specifically on intervention. So we have developed, implemented 4 different protocols, all of which are composed of multiple case report forms, eligibility forms, baseline forms, and then at multiple time points, at defined time points, post-transplant. And now, as I mentioned, in the next cycle, we will also include a protocol on PIRD. We have funded 18 research fellowships and 6 pilot projects. We have produced over 80 publications. We've been working, especially in more recent years, in very close collaboration with another network that actually has a long history, which is the Inborn Error Working Party of the European Blood and Bone Marrow Transplantation, or the European Society for Immunodeficiencies, and that already has resulted in a number of projects that are the result of a joint effort between IEWP and PIDTC, and we have several other projects ongoing. We have developed the first prospective study of targeted busulfan dosing in hematopoietic stem cell transplantation for newly diagnosed babies with SCID. This is called the Seaside project, which is important because now that we have newborn screening available, of course, we want to refer to transplant as soon as possible these babies, but there were very little data in terms of how much busulfan is needed in babies and to correct the disease. And so this is going to be a randomized, it's already recruiting patients, is a randomized study assessing 2 different doses of busulfan in a number of severe combined immunodeficiency conditions to define what is the optimal and safest approach to transplant. That's exactly what we wanted to do, a prospective trial in immunodeficiency. This study is NIH funded. It is open to all of the centers of the PIDTC as well as of PBMTC. We have completed also 2 survey projects with the patient advocacy groups for the WISCOT on quality of life and non-medical supportive care. And we have ongoing studies on neurological outcome and quality of life in other diseases. Now, it's also important to give some consideration of what lessons have we learned, especially if you're going to move towards some worldwide or regional similar consortia. I think it's important to here what we have learned, and sometimes we have learned the hard way. A very strong biostatistical support is absolutely needed. This was paid through the U54 grant that we got from the NIH, but I have to mention that we often had to request supplements. There is a lot of biostatistical support really needed for querying the centers, for data cleaning, data analysis. We also realized that when you develop different protocols for different diseases, and so you have case report forms for all of them, you should work together from the very beginning, trying to use a common terminology, because otherwise it becomes impossible to do across protocols studies. And so again, this is not exactly what we did initially. We're now doing this. So we have a joint committee that supervises all protocols for all different diseases. Developing protocols and study-specific case report forms takes a significant amount of time. In our case, it took a year before we actually could start any of the 3 or the 4 protocols that were part of the PIDTC study. Protocol working teams should work in parallel, and an overarching committee may ensure use of a common format. That is exactly what I mentioned before. Completing the forms in an accurate manner takes a significant amount of time. This is different in the US and in Europe, and I don't know about areas of the world. In Europe, we used to do this for free. Basically, nurses and physicians would enter this data. They would not be remunerated because this would be considered part of their job. In the United States, that's not the case. You need to provide, you need to compensate for the time that the nurses and the physicians spend to enter the data. So having a good remuneration is actually essential to the success of the initiative. And actually, we did increase over time the amount of money that was given back to the center for any CRF that was completed. The data cleanup is also extremely important. As much effort and attention physicians and nurses pay in completing the CRFs, there will always be mistakes. And so one of the things we learned is that if you wait too long to analyze whether the CRFs were completed correctly or not, it will take a long time and a lot of effort to go back to the medical records and correct those errors. So we're now doing this periodically, and ideally should be done quarterly. So again, this is something also to be considered. And finally, and very importantly and unexpectedly, we thought that by initially selecting the main centers, we would collect the majority of the patients that actually are affected by these disorders and receive transplantation or gene therapy for these diseases. But in fact, that is not what happened. So even if we performed a survey initially and picked up the centers that actually in our minds would collect the majority of the patients, in retrospect, we have now come up with this figure that only 49% of all expected new cases of SCID have been enrolled in the PIDTC 6901, the prospective protocol for severe combined immunodeficiency. So that means that a lot of patients are transplanted at minor, so-called minor centers that transplant few patients. Collecting information on those patients is as important as collecting information on patients that are treated at major centers, because otherwise we provide a biased representation of what is the outcome of patients with those diseases in our country. And I'll leave it there, and we'll now listen what Marco has to tell us about PRINTO.
Thank you very much. Thank you very much, Raffaella, to give me the opportunity to present what we are doing from the other part of the ocean in Europe on autoinflammatory disease. Thank you. Thanks to the PRINTO network, and this is related to an initiative on autoinflammatory disease that is called Eurofever, that came from a grant that we have in 2009 for a European grant, and that of course was related to the presence of the extreme fragmentation of the cases in different centers and countries, and at that time we have very little information of the new field, new diseases, on genotype-phenotype correlation, how it can respond to treatment, and also we need to increase the awareness of the disease in many countries, especially in the eastern part of Europe at that time. And also because of the fragmentation of the patient, the few patients, especially for rare disease, it's very difficult to perform non-profit clinical study or therapeutic studies in this rare condition. That was the reason why we set up a registry that was a rather complex registry because it has many information on demographic information, a section that has all the clinical features, rather detailed clinical features in terms of description of the fever episode and also the clinical manifestation and the blood examination, imaging, and so on. And then there is this new part of the longitudinal study, because what we want to know is what happens in this patient when we treat this patient with the different biologic drugs in terms of efficacy and safety in the long run. That was the end. We follow the same strategy that Gigi alluded to. We build up a common CRF for all the diseases, because this is very important. I will show you the possibility, that give you the possibility to compare the different diseases and also to build up, as we did, classification criteria and so on to distinguish different diseases. We take advantage of the PRINTO network, that is the counterpart, the European counterpart of Paediatric Rheumatology Collaborative Study Group here in US. It's a large network that is was funded by Professor Martini and also run by Nicola Roberto, and is a large network of more than 51 countries with more than 300 centers that is dealing with clinical trials and clinical studies in pediatric rheumatology in general. Since we had this very large network, we think that we have the possibility to use the network to spread the notion of this registry in these different countries. For the first time, we open also as a PRINTO the possibility to have adult centers, because this is a pediatric rheumatology network PRINTO, but for Eurofever we decided to also to open to adult centers. That was very important for us because, as you know, this is not just a pediatric field, but is a field in which adults have to be in, and that was very important for us. And after 4 years, 10 years of recruitment, you can see here now 90 centers has been involved in 62 countries, not only in Europe but also in Southeastern Mediterranean, in Asia, and in South America. And the number of patients are very relevant. As you can see here, more than 4,000 patients with all the different rare autoinflammatory diseases. What is quite interesting that we observe after the first description of the first paper in 2012, in which the distribution were mainly in the Western European country, what was quite interesting is that we have a huge increase in especially in Central Eastern Europe and also in Asia of the patients. That this is what quite interesting and quite important for us, because one of the main, let's say, goal was to increase awareness and also the possibility to the recognition of the patient in the part of the world in which these diseases were really not known. And so we're very happy to see the increase of the enrollment of patients coming from different areas. That was one of the goals. So the only let's say great goal of one of the most important is to provide scientific evidence and clinical scientific data, and that was possible with almost 20 publications now with a lot of co-authors, as you can see from many centers, 81 centers, and it had a quite good let's say impact on the literature with a lot of citation that I think is quite important. That is mainly related to most of these papers were published on high-rank journal on rheumatology. I think that is related to the quality of the data that we were able to affect, and that is really linked to how you build up the CRF and of course how a patient is the effort of the centers to enter the data in the correct way and also to clean the data very frequently. This is something that PRINTO is doing very well. And we are doing a number of studies that are ongoing on different diseases, which are the achievement of this registry. Many topics. We have new demographic information of distribution of the different diseases around Europe, but also in other countries. We have the data of the natural history of the main condition and rare condition in which we did not have any formal, let's say, data in big let's say, cohort. And also, this is very important. This is one of the last papers. We start to study the undifferentiated patient with autoinflammatory disease. That is a very important and very relevant group, and we are following them also in a longitudinal way, just to understand if there are, of course, new genes, but also how we can treat this particularly very important, relevant clinical entity. We provide many evidence on response to treatment in this condition. We develop together with our French colleague new tools for and validate also new tools for the disease activity score, that is IDI, that is quite useful in to follow patient with periodic fever. And also we develop evidence-based classification criteria and also validated these criteria for the classification of essentially the main autoinflammatory diseases, and that was possible through the combination of the different diseases, that the statistical analysis that came from this combination. Just to finish with the big work of these two fellows in Genoa, Riccardo and Matteo, that were able to collect all the data coming from the different diseases, especially for the main diseases, and to give us a sort of collection of genotype-phenotype association in hereditary periodic syndrome in this journal, that is an online journal, and also on the Eurofever website. You can go to all the different mutations, for example, here for TRAPS, and to see for all the different mutations how many patients are present in the Eurofever registry, which are the clinical characteristic, the less common manifestation, the response to treatment, and also the complication according to that specific mutation. So it's something that could be useful in the daily practice. So in conclusion, we think that this effort, thanks to PRINTO and all the community of Pediatric Rheumatology Society, Eurofever contributed to increase the knowledge on autoinflammatory disease, to improve the early recognition of the disease, increase the awareness in some region, especially in Central Eastern Europe, and I hope also in Asia. Dynamic registry. This is a dynamic registry because you can understand there is a continuous update of the registry with the new diseases. We start with just 12 diseases, and now we have all the clinical variable of 30 diseases. So, and is a continuous let's say, update with new clinical manifestation, new data from the lab, and so on, that are pertinent to the new diseases that are discovered year by year. So is dynamic registry. And now is a longitudinal registry, as I told you, that is very important in our view to see the efficacy, the safety, and also the quality of life, and also some data on pharmacoeconomics that are very relevant in accordance to the cost of the drugs. And the registry have to live forever, so the enrollment is always ongoing. And so, I mean, this is the invitation that we usually give to the Europeans and the people that is not only, but also the people that some are here in this room to continue to enroll, because I think it's very important. So these are all the people that are in the steering committee, the people enrolled working on this, and especially the people from Genoa, especially Nicola Ruperto, Professor Martini, and the other people here, that the research assistant and the webmaster that are really in charge of how the system is going on. Thank you very much indeed.
Questions. First to GD, how many, when you say strong statistical support, does this mean 1, 5, 10 people, or how many actually does that specifically mean, or can one actually come up with a number?
Yeah, so we started actually with the main biostatistician that CIBMTR uses, because some of our forms are actually evaluated by CIBMTR. He's a very experienced biostatistical person. It was not enough. So every time we had actually to associate between 1 and 2 more biostat people for individual studies. So there's no way that one person only can manage so many data. So I would say 2 to 3 is probably what is needed. It depends, of course, of how many diseases you're dealing with.
And Marco, thanks for your advice and presentation as well. I have one question when it comes to registry data, because that hasn't come up from us, but it has also come up from the parent organization. Have you considered self-registration? Because it takes sometimes a lot of time to actually put all the data in that is required for Eurofever, which for people who don't have anybody to support data entry has been a problem. So have you kind of dealt with a more reduced kind of registry that actually allows to get better prevalence data, because we're still lacking major prevalence data for many of the autoinflammatory diseases?
Yes, I mean, of course, this is is rather challenging. We have the same, let's say, philosophy, European philosophy, that including patient in the registry is part of our duty in Europe. But however, I understand that that is not that easy and is time consuming. We try to make the registry, I don't enter in the technical detail, as fast as possible with some tricks that, let's say, allow you to go through the process not in a fast way, let's say. However, I understand that is rather tricky. I think that for your specific question, there is a part on demographic part that is very short. There are 3 parts: demographic part, as I showed, the clinical stuff, and the longitudinal part related to the efficacy of the drug. If all the centers start to complete the demographic part, that it takes 5 minutes, 10 minutes to be, we would have, even if they do not go on, maybe later on with the clinical manifestation and later on with the longitudinal part, if they are able to start with that, we will have a number of very relevant questions on the demographic part. So that would be something very easy to do, very, very quick, and very useful in my opinion. So, and this could be step by step. Also related to the patient, our dream is to to increase the longitudinal part to the possibility to give the possibility to the patient to enter their data, especially related to some tools with quality of life, disease activity, or what they think about their disease control and so on. So that will be, this is our goal in the next future, if you are able to have the possibility to the patient to enter directly when the doctor enter the data from in the longitudinal part, the parents, the patient can enter some data on quality of life and other stuff.
I think talking to bioinformaticians to find if they're on platforms where you put the data once and then it can be pulled in different databases at the same time would be helpful, because putting demographic data in here, we're already doing this in 3 different places. So,
oh, yes. You know. For the demographic data is not that difficult.
No, it's just what I'm saying is you actually, in order to keep the data, it's already in databases here. So you're re-entering the same data 3 or 4 times. Yeah. And I think whether there would be just ways to kind of generate something like platforms that can be web shared, where you can actually pull certain data. And I think that would make life a lot easier and help us share. Has anybody any experience with that?
The problem is the medical records, the format of the medical records. For instance, NIH uses a totally different system. We don't use EPIC. Many centers in the US use EPIC. So if you use different systems, they don't talk to each other. That is the major problem.
Download data to a kind of warehouse and then actually import from the warehouse, something like that, because I think that would make interaction of different networks on a database, I mean, particularly collecting data, so much easier. And I don't know if anybody has any experience with that, because I think it would basically be, there are web tools available where that can be done, where you just basically allow data to get in and out.
I think with the medical systems in the States now, like, so you can pull data from the medical records to RedCap kind of platforms. I think that can be something. But for the patient thing, I have one thing to say. There's still a lot of places that patients are not able to access to care. So like if the care can go to the patients, and we need to find ways to have them able to enter their data without moving from where they are, because that's the issue.
Absolutely. I agree. Cecilia.
Marco, one quick question. For the patient part, have you thought, because of the recurrent fevers, it's so hard for the patients to remember what happened from when they go to clinic, have you thought about using like an app or something like that where they can enter this kind of day-to-day data?
That will be very important. Theoretically, the IDI already, that is the tool that is focusing on disease activity in periodic fever, is if there is an app that you can use, and indeed could help, of course, in registering all the fever episodes during the year, for example. The problem is that we have to insist with the family to include the data in this system that is very easy. It's a daily diary, in which you sign the clinical manifestation. If you have fever, abdominal pain, and so on, so you click, and then there is a score, and you can follow indeed if the patient have fever episode during the last 6 months or something like that. No, I mean, it really depends. Is a center, we understood that it is center, let's say, derived. I mean, there are centers in which the doctors push a lot the patient, and please come with your IDI every time or any visit, and they do it, and it's very useful because you have the information. The other centers are a little bit more lazy and more pushing with the parents. So I mean, the variable are not the patient, I understand, but are the doctors.
One one more question. That was one of the charges that came from the parents, and that had to do with transition, as you know. Have you dealt with using your network to kind of include awareness on the adult side and actually help with transition, either on the PID side or on the PRINTO side?
Yes, I mean, of course, the dream will be to involve more and more adult rheumatology in this network. That is not that easy because, again, we are lucky enough to little by little to involve some pediatric adult rheumatology centers. That is very important because theoretically they think that this kind of disease, rare disease, monogenic disease, are not pertinent to their work, but some of them start to enter in the network. This facilitates a lot, of course, the transition, because if they are involved in the network, of course, it's much more easy to transfer the patient when they are adult. Of course, we have some historical adult centers around Europe that are taking care of autoinflammatory disease, but the idea is to try to enter in the adult rheumatology field that is very large, but a little bit reluctant to be involved because of the mentality that these are pediatric diseases. That is not true. It's very important, however.
I mean, for transplant, historically, the majority of the centers are pediatric centers, but there are centers that actually don't really look at age. I mean, Memorial Sloan Kettering, for instance, transplants children and adults the same way. So you have the same physician basically involved that follows the patients throughout, the same group of physicians. We don't necessarily restrict it to pediatric centers. So our network includes both pediatric and adult centers, and some of these patients are transplanted later in life. SCID, of course, will be transplanted only in childhood, but they will receive gene therapy at the NIH at an adult age. So.
And who follows them long term?
Well, that is an important question because, patients move, especially in this country. They move quite a lot. And physicians move. And so that is a major problem. We have faced that. So our cross-sectional study, in fact, was meant to capture the current status of patients that had received transplant at least 2 years prior. But in fact, we were interested especially in patients who had received transplant 15 to 20 years ago. And only approximately 40% of these patients have been captured, just because many of them are lost to follow-up. They move elsewhere. They don't necessarily follow. There was the idea that you transplant and the disease is cured, which may or may not be true. We learned actually we need to follow these patients for a long period of time. And in some cases, the physicians have moved, and the new physician doesn't even know the patients that have been transplanted years and years before. So there is a need actually to improve on that side. Absolutely.
You need an app.
We do.
Are there any other questions? The only thing to mention is that the group of the oncology group actually has a cloud, and all the patients are entered into it, like I think CF does as well. And it can only be accessed by the patient, who will then give access to the new physician. And so that keeps up the latest treatment and so forth. And I'm happy to let you know who to contact, but it's a beautiful model for post-chemotherapy and long-term follow-up of cancer therapy. Well, thank you very much.